So, hi everybody. Welcome to the Trauma Tele Grand Rounds from the Pan American Trauma Society. My name is Adenauer. I'm from Brazil. And today my friend Gabriela is going to present a very interesting case. We have here very expert panelists. So let's going to try to respect the time. Go ahead, Gabriela. Nice to have you here.
I'm gonna share here. Is it okay? Can you see?
Yes, perfectly.
Okay. So good afternoon. My name is Gabriela Fernandes. I'm a general surgeon and a trauma surgeon at Hospital João 23, Belo Horizonte, Brazil. And thank you all for being here today and for the opportunity. Today I'm gonna present a case which is beyond the wound, management of penetrating injury at the thoracic inlet. Let me know if you don't understand my English. So just to contextualize, Hospital João 23 is a hospital specialized in the care of trauma and burn victims of the state of Minas Gerais. That's where it is located. It has around 500 beds. Talking about the ICU, we have 48 beds for adults and 20 beds for pediatrician. We have the radiology unit with CTA and with the radiologists. We have the trauma surgeons. We are always 5 surgeons in-house call, 24 hours a day, 7 days a week. We also have other departments like neurosurgery, orthopedics, and vascular surgery that are also in-house call. And we have other specialties like thoracic surgeries. And we also have hemodynamic unit, but it depends on which person is in-house call. So it's not available 24/7. So it was a Saturday around 6 p.m. In November 2025, and we got a call from the pre-hospital, and they told us that there was a man, 27 years old, with a penetrating injury in the suprasternal notch. It was a stab wound, and they told us there was a large amount of blood at the scene. About the injury, they told us it was a penetrating injury about 1 inch in the suprasternal notch. The patient was unstable hemodynamically, and he was using norepinephrine. And about the treatment, they did airway protection with oral intubation due to expanding neck hematoma in the urgent care center. So the patient got to the hospital 3 hours after the trauma. We confirmed the oral intubation. The patient had symmetric chest wall movement. The respiratory rate was 20. He had weak peripheral pulses. The heart rate was 105. The systolic pressure was 100. His skin was cold. His abdomen was soft and non-tender. The pelvis was stable. And he had this penetrating injury in suprasternal notch, about 1 inch, with active bleeding. The Glasgow Coma scale was 7. The verbal was non-testable. The pupils were equal and reactive, and no other injuries reported. So I think we could open for discussion, or can I go on?
No. Let's get something from our panelists. So, Dr. Utrecht, what would you like to do at this moment, my friend?
Yes, so actually, very interesting case. And remind me, Glasgow Coma Scale was the 7. Okay, yes. Okay, so here's a 27-year-old man in shock, stabbed in an intriguing location, suprasternal notch. So it's zone 1. and the injury with an expanding hematoma. So there are hard signs of vascular injury, and he should be in the OR. But before going to the OR, I need to take a few stabilizing measures. He's in at least class 2 shock and seems to be breathing, but I would do a quick EFAST, especially the thoracic portion, to see which side of the chest is injured or whether either side of the chest is injured. But the injury could be in the upper mediastinum, including the aortic arch, or either chest could also be penetrated. So I would do a quick EFAST. If you didn't have access to that, I would be inclined to place 2 bilateral chest tubes, bilateral IVs, which he probably already has, activate the massive transfusion protocol, give him some blood because of the tachycardia and borderline systolic pressure. And if he responds to 1 or 2 units of blood, is a stable responder, you could conceivably get a CTA, but barring that, I would do those initial things and take him straight to the OR. And based on where the injury seems to be, you prep from the chin, although regular trauma prep. And in this case, I would be inclined, if I had to commit, without knowing nothing more, if I had to commit to initial incision, it would be a median sternotomy. But really, this patient needs to be in the OR unless he is a stable responder.
Okay. Just want to check something, Gabriela. How was the breathing sounds bilaterally? Normal?
It was normal. They were present bilaterally.
So, Dr. Utorch, even though with normal breath sounds, do you think bilateral chest tubes are a good idea right now?
Well, if look, this is a judgment call, but I would be inclined to do an EFAST, query both thoracic cavities. If you can do that, and you're very, very sure that he has sliding, no signs of a pneumothorax, and there is no hemothorax, and that should be easy to confirm, then I would not put the chest tubes. But in my day, we weren't doing ultrasound until the late 90s. So, but when I was in training, you call for a chest x-ray, whatever, but if there was any doubt, you would pop in bilateral chest tubes. That's both diagnostic and therapeutic. That's kind of like, in the old days, the scalpel was the CT scan for the abdomen. If you didn't have a CT scan of the bilateral chest tubes, was the EFAST, the extended portion of the FAST. But if I would still, you can hear breath sounds, but it's a little subjective, and you don't want to be caught in the OR on positive pressure ventilation. Suddenly the patient goes into shock, and you're not sure why. That's a safety measure, but with the ultrasound, it's if you can be sure, I would leave them out.
Okay, very nice discussion. Before we move on, Gabriela said the patient was presenting active bleeding. Does any of the panelists wants to suggest any measure to control this bleeding before doing anything else? Any idea how to control a bleeding at the sternal notch at the emergency room?
Well, you can try deflating the balloon and pushing it down just a little bit, and then reinflating it. That may do something. It may not, but that's the first thing I would do.
Nice. I completely agree with you, Dr. Frisbee. Is something I think it's very useful to do in the OR, in the ER. And I think in a situation like this, it's very worth trying to do this. So, Gabriela, let's proceed.
Okay. So yeah, like the first immediate action that we did was to inflate a follow catheter in the lesion and until the bleeding had stopped. So at the resuscitation room, we control the active bleeding with the follow catheter inflated at the injury, and we started the fluid resuscitation with one large bore intravenous catheter. We replaced with 100 milliliters of crystalloid, and because he had a shock index of 1.1, we started with 2 units of red blood cells and also 1 gram of tranexamic acid.
You were moderating.
We did the fast, it was negative. We did not do the e-fast as the doctor said before, but we did the fast, it was negative, confirmed with the radiologist. And we did a chest x-ray in the resuscitation room without, it was normal. So after 15 minutes, the patient was stable. His heart rate was 62. The systolic pressure was 130, and he had strong peripheral pulses. So we took him to the CT angiography of the neck and the chest. So let me see if I can share with you the findings. Just a second. I think, okay. Well, in the coronal plane, we were able to identify extravasation of intravenous contrast. As we can see as a bright white, this high density spot right after the branch of the brachiocephalic artery. So we suppose there was a lesion of the right common carotid artery. You can compare with the axial plane. As you can see, the same extravasation of contrast. I tried to reconstruct the image because we did the contrast in the arm ipsilateral to the lesion. There was a lot of artifacts, but we can see the lesion of the artery. So now.
Okay, so who wants to contribute right now? Dr. Hodgman, do you have any ideas?
Well, a few things. Where the injury was, yes, you suspect injury to the arch, to the vessels coming out from the arch, and to the venous structures, like the innominate vein crossing in that area. I will be honest, I suspected the venous injury more than an arterial injury because the patient presented 3 hours later, and I'm surprised that he managed to survive for 3 hours with an active arterial bleed. But anyway, so if how to approach this, if I wouldn't have the CT scan, I would have proceeded with a median sternotomy. Now that I have the CT scan, based on the location, I will proceed again with a median sternotomy, but have everything prepared to extend the incision over the anterior border of the right sternocleidomastoid muscle. I would not address the injury directly, so that's the reason I was starting with the median sternotomy, dissect the innominate artery, put a loop around the innominate artery before doing the dissection in the neck very distally, so I can put a vessel loop around the carotid artery more distally. So I would not go straight to the hematoma. So that's the thing. That would be my approach for this. I would not do, some people try to do a limited sternotomy and a trapdoor incision and whatever. I don't find those particularly useful for trauma because they take too much time to be done. They have significant morbidity. If you Sometimes you don't get good exposure. So I would prefer to do a median sternotomy with incision in front of the sternocleidomastoid muscle. Thank you.
Fantastic. You know, just a small contribution for this discussion by my own. Every time I talk with my friends from US or from Europe, I get the idea that because they have such an efficient transfer system, we think completely different. For example, I work here in the Amazon region, and I had many cases of arterial injuries, carotid injuries, femoral injuries that arrived to my trauma center about 12 hours after the injury. So because I had that kind of case, when I see a case that got 3 hours after the injury to Gabriella's hospital, I think, wow, fantastic. And because of the type of the bleeding, I also think this can be an arterial injury. Regarding the access, I don't think trapdoor is a good idea for right side injuries. It can be an option for left side injuries, especially for subclavian injuries. But nowadays we know that median sternotomy will solve about 95% of these injuries, either from the right side or the left side. And if I had the chance, for me, an injury like this would be a nice case for putting a cover graft, a stent graft. But of course, here in my region, I don't have this for the public health system, only in the private hospitals. It's very different here in Brazil. So in this case, I agree with the median sternotomy. Let's discover what Gabriela did. So how did you solve that problem, Gabriela?
Okay, so moving on. Well, the patient was now hemodynamically stable. So, well, I had with me other colleagues. One of them is Rodrigo, and we really appreciate this book. I think it taught us a lot. In chapter 13, it says about thoracic vascular trauma for the general surgeon. And the tip that they give us is follow a trail of safety in exploring an upper mediastinal hematoma. So yeah, the first step was to do a median sternotomy to do the vascular proximal control. The patient had a super hematoma in mediastinal superior, but it was not necessary to explore it, and it was not necessary to open the pericardium because we could do the vascular proximal control of the brachiocephalic artery. The second step was to identify the gatekeepers. So in this situation, it would be the left innominate vein because it's right before the branch of the brachiocephalic artery. After that, we did the right cervicotomy to do the vascular distal control. So yeah, you can see the vascular distal control of the right common artery. And as you can see, so you can see the left innominate vein, the right common carotid artery with the vascular control, and also the brachiocephalic artery with the control. So after that, we did the dissection and we found the hole, and we could repair the lesion with stitches. And the vascular team, they came to help us in this part of the surgery. And the last step was to put a mediastinian drain. Here in Brazil, it's more common to use this tubular drain that is more available in our public hospitals. So the patient was admitted in the hospital in 29 of November, 3 days after he was extubated in the ICU. His Glasgow was 15. He went to floor bed the day after. The drain came out 3 days after, and 1 week after the admission, he was in his house.
Very nice. Congratulations. I just want to ask you two things. I know this can be strange for our friends that are not in Brazil, but here we not always have the external saw, the electric one.
Yeah.
So, did you have the saw?
No.
So, how did you open the external? I know it may be strange to ask this, but we know that there are different ways to improvise and to open the external if you don't have an electric saw. And I think it's very interesting to discuss how to open the external if you don't have the electric one.
Well, then I don't know if I will know the name in English, but we used
Jiggly saw.
yeah.
Okay,
Yes.
nice, nice. And how did you pass it? I'm asking this because if you're not used to do this a lot, and when you try to do this, you need to have like a curve and long instrument.
Yeah, we did like that.
Okay, but then when you try to open it, sometimes you don't have room to open it because of the anatomy. So a very interesting tip is to put an umbilical tape already on the clamp, and then when you got to the sternal knot, you take that umbilical tape, and then you tie it to the jiggly saw, and then you pull it back, and it's an interesting thing. The second thing, it's not clear for me, is how was the carotid repair? Simple stitches. What do they do? What did they do?
A continuous stitch, a continuous one.
5-0 Perlin.
Perlin.
Okay, and did you get to put some saline with heparin, or you just stitch the injured carotid?
They put heparin.
That's very, very important to do, because if you don't do it, the endothelial injury, the endothelial lesion, will probably lead to a later thrombosis of the arterial injury. Okay, so who else is here? Is my friend Felipe Vega was here from Mexico. Are you there, Felipe? I think Felipe is not here anymore with us. Any ideas here, Dr. Frisbee? Do you want to contribute with anything else? Dr. Ultrich, anyone?
Well, let's see. Do you know what a Lepsky knife is?
Do you know, Gabriel?
I think so, yeah.
That's what I use. I don't bother with the electric saw, mainly because I don't know what's below there, and I don't want to cut anything. So I just use my strong left hand to hold it up, and hook it in there, and tap it till it comes up. It takes about 15 seconds. So that's what I use. Second thing, you said he got to you 3 hours after his injury.
Yes.
I have just an observation. Um, why did you give him Tex, tranexamic acid?
Okay. So it was like about 3 hours, not more than 3 hours.
Okay, all right. Well, I think that's fine. The thing about lateral closure of an artery that high up is you need about 3,000 units of heparin, and just to protect that that suture line, and so that it won't clot off. You don't have to keep them on heparin, but you need that while you're operating, and that the rest of it sounds fine to me. That's all I've got.
Dr. Utrecht, do you want to?
Yeah, so very, very nice case. And I liked your comment, Dr. Adenauer, about the covered stent. In certainly in 50 years, if not during the lifetime of us old guys on the panel, that'll be the way it's done in hospitals that have the capability. And all hospitals, they'll have robots, they'll have hybrid rooms, whatever, the big facilities. So, and that would take care of it. Just a couple of points. First of all, the thing about it's a good case to remind, don't forget putting the Foley catheter in. And seeing the picture, I would have maybe put my finger in to try and see which way the wound went. And then, you probably would have been able to feel the injury. Just a question based on all the information you had. So, as Dr. Hochman said, and I agree with him, without knowing exactly what you're dealing with, I would have done the median sternotomy, but you knew exactly what you were dealing with. The injury was in the common carotid. Could you have simply done the anterior sternocleidomastoid incision on the right and gotten control, in the common carotid distal to the takeoff of the right subclavian without doing the sternotomy? Because given the fact that you had all that great information and you didn't have access to the covered stent, so you had to go in, could you have done that? That would be my one question. And then the other point is, as you know, if you're in a pinch, if you're really out in the boondocks and out in the Amazon, literally in the Amazon, and you don't have vascular sutures, whatever, especially if you get proximal control and you see you have back bleeding through the wound, the common carotid can safely be ligated. If it's better to repair it. I would want mine repaired, but you could have easily ligated above and below, and the laceration you would have had maintained flow through the collaterals across the face. And if that's the case, if the intima, the common carotid, would have thrombosed, just an opinion from my colleagues, do you think it would have propagated down to occlude the right subclavian and above past the bifurcation of the carotid? I think probably not, because there would have been adequate flow to prevent those, to prevent the clot from propagating outside the common carotid. But if that's the case, then there's really no worries, if it thrombosed. But, it's better to just heparinize the patient, as in this case, limited bleeding. But actually, excellent case for discussion. And remember, put the Foley in, or explore with your finger, and then, have the medical students just, walk with you to the OR, keep his finger there, and whatever, and then take it out at the last minute or exchange for the Foley catheter. But very nice case, very nicely done.
Well, doctor, I think that we could have done upper sternotomy, not like the median. I think but I have more experience doing the median sternotomy. I've seen a class of Adenauer that he showed us that it was possible to do only the upper one. I think in this case it was a possibility. And about the vascular team, they chose to do this type of repair, but I think there are other options as well.
Yeah, no, the repair is, I agree fully. If you had multiple injuries and the patient was in bad shape, you need to get out of the OR, I think that's a definitive treatment for this, for the injury. But given the circumstances, no, I would have been a little critical of simply ligating if you had other options.
Okay.
I think it's very important to remember that according to all the guidelines, if the patient, if you are able to repair a common or internal carotid injury, you should do it, because only about 25% of us have a Willis circle like we have studied in the med school. And I know the fact that if you have a back bleeding, a good back bleeding, it's a indirect suggestion
Fine.
that you have a good Willis circle. But if it's incomplete and this patient gets hypotensive, even though like this, you can close the collaterals and then you have ischemic stroke. So if you are able to reconstruct, it's always better. And one question from my own: did you guys prescribe any special medication after the discharge or not?
No. No, like after discharge, no.
You know, I will
Should be
share something that's
okay.
completely off-label, but you know, sometimes in trauma, we decide to do some things that are off-label.
Yeah.
So there is no scientific justification here, but specifically for carotid injuries, I usually recommend to give aspirin for the patients after the discharge, because
For how long?
well, that's going to depend, but at least for 3 months, because after
Okay.
3 months you have endothelialization. The endothelium will cover the proline stitches from the inside. But you know, that's the only artery I'm afraid to get thrombosis. And if the femoral artery thrombosis, the patient has hours to get it fixed. But if this patient has a thrombose at the carotid artery and he's going to take hours to get it fixed, the patient already got the stroke. So
Okay.
I know that's not written in any guideline, but I personally feel safer for doing this.
Thank you.
Okay, any other different thoughts here? I think we covered the Foley in the ER. I agree with Gabriela. I think that if normal breath sounds, normal X-ray, I would not put bilateral chest tubes, but I understand the point of doing this. Sometimes we need to be a little more aggressive in the first survey. I think median sternotomy is a very nice option here. And I know we talk about the partial sternotomy. It's feasible, but you know, that's the kind of situation that you need to do what you feel most comfortable doing. Things are already very difficult. So if you feel comfortable with the complete sternotomy, go ahead. I would not advocate for only cervicotomy in this case. I think doing a cervicotomy, it's not going to provide you a proximal exposition that you need to have before reaching the injury in this specific case, because you know you had the image, so you can judge that. Stitches, never forget local anticoagulation. I think we cover all the important aspects here. Does anyone want to discuss anything else?
Well,
Yes,
I have a question.
Dr. Albert, please share that question.
Yes, I just want to talk a little bit about the pre-surgical aspect. I'm an anesthesiologist, not a surgeon, so I will not comment on the surgical aspects. But, you know, penetrating neck injuries, this is a big deal from the kind of injuries that you can expect with a very high mortality. And I think, Gabriela, you were lucky that the patient came already with airway secured. Somebody who has a carotid blowout, once you get that hematoma, you really can't intubate. And trying to do a emergency surgical airway, even at Craig, is pretty dangerous. So whoever pre-hospital secure the airway, you know, congrats from that standpoint. Now, is there a way, if you could, I can share my screen for a second?
Yeah, of course. I'm
Okay,
gonna stop here.
okay. So the patient had a zone 1, correct? Basically, it was just above the sternum. So
Yeah.
that's the injury that has the highest mortality. Now, that's not a new concept. Okay, so this is Rubens' tapestry painting showing Achilles killing Hector. And the Homer and the Iliad call this the shorter way to death. You want to kill somebody? That's where you stick the sword, basically. And for those in the United States that saw the movie with Brad Pitt, and let me see if I can do this. Yeah. Let's see if I can do that. That different zone 1. So the bottom line is that it's really a very dangerous injury. So the fact that the patient survived, with your efforts is just amazing when you have this type of injury. Again, you have vascular injury is the largest issue when it's a zone 1. So the fact that you put large IV access was essential in this case. And obviously, let others discuss the surgical technique. Thank you. This was a very interesting case.
But
Thank you.
Dr. Verone, he's really prepared with beautiful, with classical literature and beautiful videos. But, what about the effect? It's really intriguing, Dr. Goes and Dr. Souza. This patient was 3 hours, so they're automatically selected for the cases that survive. So you're not seeing those, so what do you think is happening for every one of these that presents? What fraction of all of the injured patients is that? And it sounds like the people in the field, the urgent care centers, they used to seeing all these, and that's so they knew to intubate the patient, and probably they see all the others that die before they get there or die on the way out. But what do you think about that? The effect of the big delays in your country?
Well, like here in my city, Belo Horizonte, we have a pact with the police. So every penetrating trauma, they need to go to a hospital and not to the urgent care center, because we know that they have limitations. But it happens sometimes that like maybe the person they got to the center by himself or something like that. But normally the patient goes directly to our hospital. Because we have all the equipment to do the best attention.
No, but I mean that results in delay. So what about
Yeah.
the effect on delay and the cases you see, the cases you don't see, where they get taken? So maybe the urgent care center is the place where they intubate the patient, put the Foley in.
Yeah.
I would have been amazed if the patient came to you intubated with the Foley in place.
Dr. Otrich, the facts, the ugly truth is that urgent care centers in Brazil have the recently graduated doctor that sometimes is not able to do skin stitches.
Yeah.
And if you get a case like this to a urgent care center, probably the doctor who is going to be there will not be able to intubate and will not be able to put a Foley catheter. So that's why they take it directly to the trauma hospital where Gabriela works. The first time I started doing research on this in Brazil, I think 10 years ago, I published a paper called Vascular Trauma in the Amazon, the challenge of the big distances. And we tracked all the vascular trauma cases that got to the hospital, and no one was brought by air evac, only by ambulance. And my state is twice the size of France. So everything that survived got to the hospital where I worked until December 2022. I'm not on the front line anymore. Now I'm on the backstage of the trauma, but it was terrible. So we published it and we tracked every vascular trauma case, and we showed to the public administration that if the patient suffered a vascular more than more than 200 kilometers, I don't know in miles, from the hospital. The death probability and the probability to lose the limb was statistically higher. So we measured all that. We know the impact of delaying in Brazil, but we have different Brazils. My state is completely different from Minas Gerais, where Gabriela is. So that's the fact.
But you know, if I can just add to that, so maybe the solution is what's done in the military, what we do in Baghdad, is that to put certainly, you know, the first people just out of medical school need to be with higher trained people in the big cities, and then you put some of the more experienced people, or you rotate through your trauma surgeons to spend some time, and that the purpose of the urgent care center is urgent care. So, you know, not just head colds that can be done by a nurse in the field or somebody's grandmother has seen it before, but just and to stabilize the patient enough to make it to the next level of care so that they won't die en route, so that the 3 hours is okay. And in this case, intubation was beautiful. And then, you know, the Foley catheter would have stopped bleeding and they would have had control, you know, and then, you know, everything is great. Those are the ones that, you know, this one survived, but despite the lack of control. But, you know, maybe that's the solution, you know, a different approach to organization and stabilizing to get to the next level of care.
Yeah, I think discussing this is very important. And we have very different scenarios from all over the world. And Brazil is so big that we also have very different scenarios in the same country. I was part of an international delegation that just got back from Israel. I was there with Carlos Ordonez and Salamea and the other guys. And the system that they showed us is completely different. They teach the military doctors there that the only thing they need to do at the Gaza Strip is to put a tourniquet and then put the patient in the helicopter, because Israel is so small and they are so efficient that in 15 minutes they take the injured soldier from the battlefield to the trauma center. But you know, this is not our reality here.
Something that we can do as well, and we are trying to do in the small cities here in my state, is to take the AT courses. So I think the doctors that are getting out of the schools are able to do the first steps in the attention of the trauma patients. I think that's a good way to achieve the better results in the urgent centers as well.
Gabriela, I have a question.
Oh, I'm sorry.
That's all right. When you were about to do the closure of the wound of the carotid, was any thought given to just doing a stump pressure?
We did not think about that, sir.
Okay.
Only to pressure, you mean?
A stump pressure is just putting a sensor in above the level of the injury,
Okay.
and getting the pressure that's coming down from the other side, really. I'm not a vascular surgeon, but the number 50 rings in my head. If you get, 50 millimeters of mercury, you've got adequate contralateral flow, and you don't have to worry about it. Just close it off rather than go through all of this. But you did a great job. Thank you.
The idea is to make sure you have an intact circle of Willis, so you'll have perfusion, and basically you put a catheter in the stump and measure the pressure, just like you do for an A-line.
Okay.
Something that's very important to be stated here is that concept comes from the elective carotid endarterectomy. And it's very important to remember that trauma is a completely different game. If you perform a carotid endarterectomy, this patient's not going to be hypotensive. This patient is not going to be on shock. And it's important to remember that when you have hypotension, collaterals close. So just keep that in mind. It can be useful, but it's not the same thing, okay?
Well said.
If I can make two comments. One is follow up with what Dr. Adenauer just said. The trauma patients are different. They are hypotensive. They may have other injuries that will cause hypotension later on. And also, the number I knew was 40 millimeters mean arterial pressure. Maybe Dr. Friedrich, where you practice, was 50. However, it's for elective cases, and it's really complicated to set everything up. You're in an emergency situation. You just need to keep moving. So I wouldn't do that. I would either ligate or repair. And again, I prefer to ligate. I always afraid of repair. I always afraid of a stroke, particularly in a young patient. So I would repair. Regarding the intubation that Dr. Baron was mentioned, again, we're talking about different patients. It's true that we don't have those prolonged transport time here in most places in the United States. There was a time I used to practice in North Carolina where we have sometimes 2 or 3 hours transport time. But in general, the transport time in the main cities in the United States where you have the trauma centers are very short. In a patient with a neck injury, my personal preference, okay, and I know that what I'm going to say is controversial, I try to delay, if it's possible, I try to delay the intubation until the patient is in the operating room. I have seen too many things that appear to be an easy intubation and the trachea is completely transected and the ET tube will end up inside the carotid. So I would rather have this in a controlled environment that if I have to convert to something surgical, I have everything there. Anesthesia can do this on the fiber optic, have a better view. So this is ideal. Again, patient like this, a patient initially I thought that maybe it was a venous injury because usually they, as I think it was Dr. Frisbee commented, they self-select. The patient that they get to you is the one that for some reason kind of thrombose this. But the patients with massive bleeding, which is what we tend to see in major cities, you don't have too much time. They will go usually straight from the operating room, from the ED to the operating room without any further testing. And if I can, I will delay the intubation until the patient is in the operating room.
Dr. Hoffman, I agree 100%. I was commenting on long transport times, on short transport times for penetrating trauma. The sooner you can get into the ER, the better, and that's where the intubation should be performed.
Well, now that we are discussing this, a few other things. A patient like this, if presents to DD, let's play a little bit of a game because now we know what this patient had. But let's imagine that the patient presents to DD. A few things that we do here. We do something that we call, this is something that we call internally, extended primary survey. What we mean is that we do a quick primary survey and very quickly we look for holes everywhere. Make sure that doesn't have a hole in the perineum or something like that that nobody sees because the patient is covered with blood. And after that, if we can, in a patient like this, that we probably, because again, it's a little bit different patient. You have 3 hours there, so the patients self-selected. The patient that we get, they're usually in shock and we cannot do too much. We will do either, as Dr. Unkter said, a EFAS or a chest X-ray. Why? Because it might give you an idea where you need to go or what approach you need to go. Yeah, median sternotomy is the preferred approach for this type of injuries. The only caveat, and Dr. Adenauer mentioned this, if you have a left subclavian injury. For the left subclavian, the median sternotomy doesn't give you such an easy approach. It will be a better approach to do an incision in the second intercostal space on the left side. And I think that, Gabriela, you mentioned this too, that the innominate vein is usually there. And people are afraid and try to move it out because they are cardiac surgeons. The trauma surgeon will ligate the vein. We should take it out of the equation and we get a good exposure of the arch. Otherwise, you don't get exposure of the arch without ligating the vein. It's save time. So those are the other few tidbits that I had from my side.
Thank you.
Okay, I see no problem ligating the left brachiocephalic vein in damage control scenarios. I did it many times and it's very useful. I think Dr. Utrecht had rose his hand. I don't
Yeah,
know.
I just, if there are no other comments that anyone else wants to make, I wanted to ask about, the circle of Willis. Does it really apply to cases where the injury is in the common carotid? Because in that case, you don't depend on flow through the circle of Willis, but rather flow through the external carotids, the contralateral external carotid, and across the face. So I just want to be sure I'm not missing something. Does that matter in a case like this where the injury is the common carotid, not the internal carotid?
I have an opinion about that, but let's see if any other guys want to answer this before, and if needed, I can try to contribute. So the question here is, if you ligate the common carotid, is important to have a complete circle of Willis? Because Dr. Utrecht said that sometimes the contralateral external carotid can perfuse the ipsilateral external carotid, and then the flow gets to the internal one from the same side of the injury. So anyone wants to talk about that?
I would be, if I can, I will repair.
Yeah.
For the same reason that you mentioned before, this patient, this is a very long way to go to the other side. And if these patients are always hypotensive for whatever reason, they bled too much, they were sedated, whatever, and suddenly you get a stroke. So that's my bias in this case.
Okay, so I want to make sure that I want to say that I respect all the different opinions, but I'm going to share my own opinion. You learn that when you do selective brain angiography. You learn that when you put a catheter in the internal carotid, in the common carotid, and you do a lot of different angiographies, even for elective situations. So, Dr. Utrecht, when we talk about the intracranial collaterals for the Willis circle, the blood flows from one side to the other of the brain, basically by two direct paths. One is the anterior communicant artery. This connects the anterior cerebral artery from one side to the other, and these are direct branches of the internal carotid, from the internal carotid. The other is the posterior one that comes from the posterior cerebral artery that comes from the basilar. So if you have a carotid injury, forget the posterior circulation. You need to talk about the anterior circulation. So it all depends on basically from one artery, except for anatomic variations. One artery. If that doesn't work, nothing else matters. From the other side, the collateral circulation between the external carotid branches, you have the classic situation are 8 branches. They are all indirect. You don't have a direct anastomosis between the right fascial and the left fascial, between the right occipital and the left occipital. They are very tiny anastomosis, by the tissues. If you put a selective angiography, if you perform a selective angiography of the right external carotid and inject there, almost in 99.9% of the cases, you will see nothing of the left side of the face. And I had cases like this. For example, we are now preparing a paper about post-tonsillectomy bleeding. And you need to perform selective embolization of the branches of the sternocarotid. You don't see it in the angiography. So it's enough not to get a necrosis of the skin if you ligate the sternocarotid, but it's not going to be enough to give you a backflow to the brain. Okay?
Yeah, very good point. That's good evidence.
So guys, I think we have covered a lot of interest points here. If no one else wants to say anything, I will give back the podium to Gabriela so she can make her final remarks.
Okay, just a second. Well, I just want to thank you all for your attention. I think we covered a lot about penetration trauma and the thoracic inlet. Thank you for your comments, and I'm very happy to be here, and I talk in the name of my hospital, and I think that's it. Thank
Hey,
you.
nice picture that.
Yeah.
Great.
So guys,
Thank you very much, Dr. Fernandez and Dr. Goes for doing our moderating. For those interested, I put the CME information in the chat. So if you want to get credit for it, I'll leave the meeting open for a few minutes so you can all access the link. Thank you again, everybody.
okay guys, see you
Thank
next
you.
month. Bye-bye.
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 Good job, Gabriella.
Thank you. Bye-bye.
Oh, see you soon.